a broad panel of several dozen gram-negative bacteria that, again, can acquire not just one specific resistance, but dozens and dozens of different resistances. They can, have resistance to penicillins, they can have resistance to fluoroquinolones, they can have resistance to third-generation cephalosporins, there can be carbapenemase resistance, and in fact, we have situations today where some of these bugs have acquired multiple different genetic variants for antibiotic resistance. There have been cases of patients in the United States where literally all of our available antibiotics across all different classes of antibiotics no longer work, where we're literally out of options.
This is the Public Health Insight Podcast.
Hi, my name is Will, and I will be your host for this episode, along with fellow co-host Gordon.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Mr. Oliver Schacht is a corporate finance professional and expert in the molecular diagnostics industry for over 20 years. He is the CEO of OpGen, a precision medicine company harnessing the power of molecular diagnostics and bioinformatics to help combat infectious diseases. Also co-founded Cancer MDX company Epigenomics. He obtained his diploma in European Business Administration at the European School of Business in Reutwingen in London in 1994, as well as a master's degree and a PhD at the University of Cambridge. Mr. Schacht, welcome to the Public Health Insight Podcast.
Pleasure to be here.
Mr. Schacht, can you start off by telling us a bit about OpGen and let us know a bit more about your role as a CEO of this company?
Sure. Well, as you said, OpGen, a precision medicine company, we're really trying to harness the power of bioinformatics, artificial intelligence-powered algorithms to predict not only antimicrobial resistance, but actually antibiotic susceptibility as well. The company is the product of a merger and business combination between OpGen here in the United States, based out of Rockville, Maryland, and Germany-based Curatus, which I had the pleasure of heading as their CEO for the past 10 years, prior to bringing the two companies together in April 2020, in the midst of the COVID pandemic. We have products in the market for life-threatening infectious disease testing, such as pneumonia, or complicated urinary tract infection, joint infection, always with a view of combining the pathogen identification with the identification of antimicrobial resistance. It's a publicly listed company, headquartered, as I said, here in the United States and listed on NASDAQ under the ticker OpGen.
Awesome. And you mentioned that OpGen focuses on precision medicine. So what is that, and why is it an important area for us to be focusing on?
Yeah. In general, precision medicine would describe any approach whereby you try to get the right drug to the right patient for the right reason at the right time. Now, when I was in oncology at Epigenomics for 13 years, that meant choosing the right, oncology drug given a patient-specific cancer situation, but also given the specifics of the patient's genetics. Now, when you look at infectious disease, it's a bit different because it is about getting the right antibiotic to target the specific genetic makeup of the pathogens, more often than not bacterial pathogens or sometimes fungal, and making sure that your selection of antibiotics is specifically targeted to those bugs, to those bacteria that are causing the underlying disease in the patient, rather than the opposite end of the spectrum would be using a sledgehammer, which unfortunately all too often we're doing, using broad spectrum antibiotics for everyone, simply because we do not know and we're flying blind to the specific diagnostic of what the bug is and what the AMR profile looks like. So it's really about making smart choices, rational decisions about the selection of specific antibiotics in a specific patient situation to treat specific bacteria and AMR situations.
You touch on some very important points there, specifically what stuck out to me was the differentiating between what you call the sledgehammer approach, right? When we are talking about antimicrobials, antibacterials, and I think for a lot of our viewers at home, this is definitely a topic that's it's of interest, and it seems to have been becoming more and more mainstream. A lot more people are talking about it in the recent years, and that's the idea of antimicrobial resistance and antimicrobials in general. Do you mind speaking a bit about kind of what are antimicrobials for our viewers at home, or what is antimicrobial resistance for that matter?
Antibiotics are basically drugs that kill bacteria. Now, antimicrobial resistance is a naturally occurring process. It's really evolution in overdrive. It's bacteria trying to survive, and it happens naturally. So if you look at any specific space, whether it's inside the human body or it's in wastewater or in the environment, you have bacteria all over. And you have bacteria on our skin, etc. Bacteria are just trying to survive. So if a bacteria is sharing, precious little space, one of the ways to potentially get an edge for such bacteria is to acquire certain genetic mutations, tiny little changes to the makeup of the DNA of those bacteria that basically lets them survive better. And if most bacteria replicate anywhere from every 20 minutes, some every hour, others it takes, a day or more to duplicate. But what then happens if there is an advantage by having become resistant, then those bacteria that have become resistant will multiply, whereas others will die. And therefore, these resistant bugs, or sometimes especially in a hospital environment, refer to them as sort of hospital superbugs, become the dominant species. And, that could lead to situations where a patient then, if infected with such antimicrobial resistant bugs, will no longer respond to antibiotics. Because that's one of the things, one of the traits that such bacteria can acquire is the ability to continue to survive even under the stress of antibiotics as drugs, as treatments. So there's other factors, of course, that contribute, but one of them is clearly the overuse or indiscriminate use of broad-spectrum antibiotics. Every time we use broad-spectrum antibiotics, and that is the challenge, really, the conundrum here, we may clearly be saving that individual patient's life. I mean, don't get me wrong, broad-spectrum antibiotics are fantastic drugs, and they save many people's lives today. However, in the process of indiscriminately using and overusing these broad-spectrum drugs, every time we use them, there is the likelihood of bugs getting resistant. Next time around, drug may no longer work for the next patient. And so we're in fact creating and causing in our hospitals, in our intensive care units, in our wards or old people's homes, we're causing more and more bugs to become resistant. Other factors, clearly lack of hygiene. If you go to certain parts of the world whether it's wastewater, you go to parts of India, especially when a lot of the antibiotics that we're using on the planet are being manufactured in India, surrounding those plants, you'll find that the wastewater contains extraordinary amounts of antibiotics, and not surprisingly, extraordinary, multi-drug resistant bugs. Because again, that's all these bugs try to do is survive, and they're trying to survive under tremendous load of antibiotics. So that's really, it is a naturally occurring phenomenon, and the way we need to try and address this is really by being smart about finding out what the bug is, what the AMR profile looks like, and then making smart choices about how to treat it in any given individual circumstance.
So you're saying oftentimes clinicians will prescribe broad spectrum because I guess it's a little bit maybe cumbersome or resource intensive to maybe diagnose AMR. So can you speak to, how do we go about diagnosing an AMR infection so that we don't have to use broad spectrum antibiotics?
Well, you're absolutely right. So let's step back. What is the standard of care today in our hospitals here in the United States, in Europe, frankly, all around the world? Our standard of care for diagnosing bacteria and antimicrobial resistance is microbiology culture. And we've been doing it for over 130 years. It was originally discovered / invented in the late 1800s in Europe, pretty much by a German microbiologist, Robert Koch. And we're still essentially doing the same thing. You're taking a petri dish, you're putting some growth media in there, then you take your specimen and you streak it out on the plate. You incubate for a couple of days, sometimes more than a week. Because again, these bugs first need to grow. And then you look at what's growing on the plate, you then throw on antibiotics, and look what no longer grows. Now, the beauty is if the bacteria then no longer grow, bingo, you know that the bug is still susceptible to antibiotics you can effectively kill. However, if the bug continues to grow, unfortunately, you know it is now resistant to that specific antibiotic that you've put on there. Now, why do then doctors, and we're doing this, it is relatively cheap, is extremely well established. As I said, we've been doing it for 130 years. There's been a lot of innovation around automating this. So, today you have hugely sophisticated robotic lab solutions that can do, thousands, if not tens of thousands of these plates in ultra high throughput. You have automated readout systems. So the underlying challenge here is that the speed with which bacteria grow. It takes, on average, 2 to 3 days for bugs to grow, and then it takes at least an extra day for you to put on the antibiotics and then read out the final result. Now, as a doctor, if you're treating a patient, and again, we're not talking about your average flu or a mild infection where you go to your primary care physician. We're really talking about life-threatening infectious disease, patients being hospitalized, either in intensive care already or potentially on their way to an intensive care unit. And there it's about hours. You've got to get this right. This is a life and death situation. We have, at a global level, we have hundreds of thousands of patients dying every single year from antimicrobial resistant infections. It's really sort of the silent pandemic underlying the current COVID-19 pandemic. I'm sure we can get back to that. But so if you're a doctor, you're treating that patient. Your only choice, knowing that it's going to take 2 to 3 days at best for you to have an answer and know exactly what the bug is and exactly what the AMR profile is, you're not going to wait. So you're going to use your best judgment, your empiric knowledge of your local situation, of what you typically see in your hospital, in your wards, in your patients, and you use these broad spectrum antibiotics as the best choice you have at that point in the absence of any diagnostic information. So part of the solution here is also, we do now have technologies available globally that allow testing for, the specific bugs as well as the AMR markers in a matter of hours, not days. So part of the solution here has to be to dramatically broaden the usage of rapid molecular testing. And then, based on a rational result that you have in a matter of just a few hours, either continuing where indicated with the broad spectrum, but what we've consistently seen at OpGen in clinical studies that we've done around the globe is usually between 30%, I'd say the average is probably around 50%, in some cases as high as 85% of all patients being treated with these broad spectrum antibiotics are, I'm not going to say wrongly treated, they're inadequately treated. More often than not, they're overtreated. So if you knew that you're not facing one of these superbugs with multiple resistances, you could quickly de-escalate, take away the broad spectrum and go with something as simple as an old-fashioned penicillin or, an older antibiotic. Or in other cases where you then identify the specific bug and the specific AMR pattern, you may be able to be very targeted and narrow and pick a specific antibiotic in that specific situation. Again, thereby, you're dramatically reducing side effects, for one, and you're also reducing the creation of new AMR in these bugs as you're just being way narrower and way more specific.
So it sounds like that's the very definition of precision medicine in a sense. So that's very well described.
Exactly.
So this leads me to, I'm just a little bit curious on what are those common types of AMR infections that maybe result in people being hospitalized, or those life-threatening AMR infections. I know you often talk about things like urinary tract infections, lower respiratory tract infections. Are there any ones that people might be aware of, or some of the rare, more dangerous?
Well, if you look back probably over the last 20 years, one of the most talked about superbugs is MRSA or MRSA, methicillin-resistant Staph aureus. Now, that bug, and that bug being resistant, can be responsible for a lot of different infections. I mean, it can cause pneumonia, it can cause joint infections, for example, after a hip or knee replacement surgery. It can cause, surgical wound infections after any type of surgery. It can cause urinary tract infections. And so over the last 20 plus years, there has been a tremendous amount of progress in super fast diagnosis of MRSA. A company that pioneered this was Cepheid, which today is part of Danaher. They developed a platform, called the Gene Expert, tiny little cartridge. That was the start of this idea, sample to answer. You have an easy to use platform. You drop in a sample, walk away, and you come back an hour later, frankly today probably no more than 45 minutes later, and you're going to have your answer. Is it MRSA or not? Because if it's still susceptible, you can give certain drugs. If it's already resistant, you need to resort to other drugs. Now, that's a single pathogen and a single resistance. Well understood, well diagnosed. It has come down substantially as a threat in the last 20 years. Now, what people are really concerned about in healthcare, in hospitals today, is not Staph aureus, which is a gram-positive bacterium, but a broad panel of several dozen gram-negative bacteria that, again, can acquire not just one specific resistant, but dozens and dozens of different resistances. They can, have resistance to penicillins. They can have resistance to fluoroquinolones. They can have resistance to third-generation cephalosporins. There can be carbapenemase resistance. And in fact, we have situations today where some of these bugs have acquired multiple different genetic variants for antibiotic resistance. There have been cases of patients in the United States where literally all of our available antibiotics across all different classes of antibiotics no longer work, where we're literally out of options. Now, and again, whether it's so the most common infections, if you look at just pure prevalence of disease, pneumonia is one of the leading causes of death in hospitalized patients. There's tens of thousands of deaths in the United States, in Europe, in China. In fact, pneumonia is the second leading cause of death in children. And the nature of the beast here is, again, pneumonia can be caused by well over 24 different pathogens. Gram-positive bacteria, gram-negative bacteria, fungi, some atypicals. And all of these can acquire different genetic AMR markers. So the diagnostic challenge becomes one of, I'm not just detecting Staph aureus and not just one resistance. Because if it's not that, then you're none the wiser. So right from the get-go, you need to be able to test very rapidly for dozens of different pathogens and, at least, let's call it at least 10, some would argue 15 to 20 different high prevalence genetic markers for antimicrobial resistance. And you need to be able to do that from native clinical specimens. One of the things that, again, if you look back the last 10, 15 years, the early panels that came out, the early rapid diagnostic tests, were all using blood culture, which required you to take a patient sample, run a blood culture, takes at least 12 hours, and then you run your molecular test, which is already progress, but you've just wasted 12 hours up front. So what you really want to be able to do is go straight from the sample that the nurse takes from the patient in the hospital. That sample gets sent to the microbiology lab, and you just take a tiny amount of that sample, and while you streak it out for your culture, and you still do culture, nobody is talking about replacing culture, because on the off chance that there's something super rare and really out of the expected universe of things, you don't want to deny any patient being able to find it in culture. But 95% of all cases, it's going to be one of those 24 organisms, and it's going to be one of those resistance patterns. And so pneumonia. The second, from a volume perspective, complicated urinary tract infections. A third one that is a high prevalence one is gastrointestinal infections. And then you have all sorts of surgical site infections, which again can be a very wide range. And then, of course, bloodstream infections and sepsis. So, once you've kind of covered those, you probably, again, have covered about 85-90% of all infectious disease. With, of course, there are some really concerning ones, such as CNS infections like meningitis. But again, they're fortunately, much rarer. Still critical to diagnose, but the key ones: pneumonia, urinary tract, joint infections, and then surgical site tissue and bloodstream infections.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.